Conference room number accepted. If you are the organizer, press the star key now. Otherwise, please hold. This line is now muted. This conference will now be recorded. For a menu of available commands, press star 1. There are 19 participants in the conference.
That CMS was going to dramatically get into the game of what she called alternative payment models. So what she said that by 2016, we want 30% of CMS Medicare's money flowing through these alternative payment models. That's the shared savings programs, or ACOs, that we're going to talk about today, patient-centered medical homes, and then also bundled payment programs. Well, it was actually early 2016 that they blew through that 30% goal, and I'm sure by 2018 they'll reach their goal of 50% of Medicare payments flowing through these alternative payment models. Now, lest you think that we can kind of get off scot-free and not participate in one of those because she only wants 50% of the money going through, she also said that the remaining fee-for-service payments need to be linked to quality and value in some way. And in the chart, you can kind of see what her goals were, 85% in 2016 and 90% in 2018. Now, all of us in healthcare policy knew this was coming. We weren't surprised by it. What I think I was surprised by was how aggressive the timeline was. This doesn't leave us as much time to prepare as I think any of us thought we might. And when you have an aggressive timeline like this of switching the way we're paid, it tends to favor larger systems who have experience with things like population health management and financial risk management. It also tends to favor those with deep pockets because transitions are expensive. It takes time and money and resources, human resources and capital resources, to make the transition from a payment that's pure fee-for-service. You get paid by widgets. That's fee-for-service, what we're all used to, which, by the way, is also cost-based reimbursement. It's essentially the same thing, versus these new models in which we're starting to get paid based on value, at least to some degree. Now, let's move to the next slide, and we'll talk about accountable care organizations for a second.
Slide number 3.
Slide number 4.
One more slide. Yeah, one more slide.
Slide 4.
All right, we're there.
Okay, thanks. So as I mentioned in the previous slide, the CMS has their payment goals of up to 50% in 2018 of their payments flowing through alternative payment models. And the models that they mentioned in 2015 were, again, the shared savings program, ECOs, patient-centered medical homes, and bundled payments. Now, we're going to concentrate on ACOs today. Now, all of you may be very familiar with what an ACO is, but just to get everybody on the same page, let me describe what an accountable care organization is and kind of what it does. First of all, an accountable care organization is a group of providers, and it's generally physicians and or hospitals, generally, and it's often a combination of the two, that receive a financial reward to maintain or improve care quality for a group of patients while reducing the cost of care for those patients. So the idea behind it is we take as an ACO, as a new organization, we take responsibility for a group of patients, and our responsibilities include to improve the care, that's quality and satisfaction, and reduce the cost. And if we're able to do that, we're able to share, Medicare will share in the savings that they realize from that reduced cost. Now, I mentioned here at the bottom of the slide that ACOs are just one of several, and if you go to the CMMI, the Center for Medicare and Medicaid Innovation website, you'll see that CMMI is it's not just dabbling, they're actually investing a lot in these new payment models. But ACOs are one of them that starts moving us iteratively. Some may think it's too slow, others may think it's too fast, but it's an iterative change from a volume-based world, which is fee-for-service, to one that's a value-based world in which we're increasingly paid based on the value of care that we provide. Now, I've had lots of people ask me, what is value and what is value-based payment? In fact, I was asked that very question on this webinar several months ago. So first, I don't want to make the concept of value seem simplistic, but I think I must be a simplistic mathematical guy because I think of value in a relatively simple mathematical formula. That is, if we want to increase the value of healthcare we provide, we need to do one of three things, or two of three things, or three of three things all at the same time. And that is improve the quality of care that we provide. That's patient safety, that's choosing wisely, that's core measures, etc. Also improve the patient experience. As a physician, and I think those of you who are clinicians probably believe in your hearts that when people enter the healthcare system, they're often frightened or in pain or confused, and we don't tend to make it easy for folks. But it is an important part of everyone's life, and that is healthcare. So why shouldn't we make it a positive patient experience and family experience as much as possible? And then last, we need to reduce the cost of care. We're twice as expensive per capita as any other country in the world, and arguably the care isn't twice as good as everywhere else in the world. So all of us need to be thinking about how can we use precious resources wisely. I know nobody that says, I want my taxes to go up unnecessarily, or I want to pay insurance premiums that help no one unnecessarily. So value is quality plus patient experience divided by cost. And value-based payment is payment that rewards delivering that value as opposed to simply delivering volumes of care. Volumes of care, which is fee-for-service. See as many people as you can, you eat what you kill, churn and burn, all the euphemisms for fee-for-service, heads in beds, etc. So we still need to concentrate on delivering value, and I think it's what our mothers would want, our fathers would want, our community would want as well too. So next slide.
Slide 5.
This is kind of talking about just a graphic of how financing for accountable care organizations work. So to give you a little bit of background, this is what would happen. Let's assume for a second that one of the patients that you have, or beneficiaries that you've decided to accept into your accountable care organization, is predicted by CMS to spend $10,000 of Medicare money per year. This is all of Part A. This is all of Part B. Currently, it does not include Medicare Advantage, which is Part C. It does not include drugs, which are Part D. So it's all of Part A and all of Part B costs, no matter where that patient receives the care, whether they receive it at your organization, your clinics, your hospital, or the snowbirds down in Florida or Arizona. It doesn't make any difference. It's all included. So what we find is if we believe that this one patient is going to cost Medicare $10,000 this coming year, and through the work we do in the accountable care organization, that particular patient is only billed to Medicare for that patient $9,500. So therefore, you can see that Medicare just saved $500 over what it anticipated to spend on that patient. And it's by your good management that we save that $500. Through all this time, your reimbursement for the care you provide for the patient, whether it be cost-based reimbursement, the fee-for-physician fee schedule, it all stays exactly the same. These are all reconciled at the end of the year. And at the end of the year, if our particular patient actually uses $500 less of Medicare money than it was predicted, then that $500 is available for what's called shared savings. Right now, if you perform expertly in quality and patient experience, Medicare will give back to you 50% of that savings, or $250. Now, if your quality is a little bit off, they may reduce that a little bit. So in this example, to $200 if your quality isn't just exactly where it should be. So as you can see, this is why it's called a shared savings program. If Medicare saves money, they share some of those savings with you. If they don't save any money, right now, for most ACOs in the country, not all, but for most ACOs in the country, there's no downside risk. So you don't have to pay anything back yet, for most ACOs in the country. I suspect that that's coming, so we need to get on the bandwagon of reducing these costs so we're not penalized in the future, but currently we're not penalized, for most ACOs in the country. Instead, the cost is in how do we actually provide the care management and other services necessary to actually reduce this cost. That is a cost. Now, you might say, well, I don't know if this is such a really great idea. I don't know if I really want to get involved in this. Wonder what everybody else is doing. So, Kim, let me go to slide 6 for me.
Slide 6.
Okay. So this is a map that we put together at Rupri showing where ACOs are operating by county in the United States. In particular, I want you to look at the rural counties, which I think, I'm looking at black and white, I think are kind of a dark green. So you take a look at those. Am I right about that, Kim? Are they the dark green counties?
Correct.
Okay, I'm lucky I got that right. So you can kind of see where it is. Now, Kim, if you would, flip to slide 7, and then flip back to slide 6, and then flip to slide 7 again for me.
Flipping.
Well, take a look at what's happened between 2013 and 2015. And remember the dark blue, or the kind of the teal color, are the rural counties. So lest you think this isn't happening to you, it's happening to your neighbors. So this is expanding rapidly, and we haven't yet put together the map for 2017, and it will look even more dark. So this is something that's happening despite the finance being not all that positive. People are really getting on board with ACOs across urban areas and rural areas as well too. Let's go to slide 8. We can talk a little bit about early performance of accountable care organizations.
Slide 8.
Okay, thanks. So this is some work that we've researched and also looked up. And just I thought you might be interested to know, well, what's actually happening with these new ACOs? Because remember, and I did mention this before, the ACOs, the concept of ACOs really kind of got going in the Affordable Care Act of 2010, meaning they really didn't get started till 2012, 2013. So these are relatively new organizations, relatively new beasts. So I thought maybe it'd be interesting to see kind of where some of the early performance has been showing up. And what we found is that when independent primary care groups get together to form an ACO, they seem to be kind of doing the best at reducing costs. And that kind of makes sense to me. It makes sense to me that physicians, other providers, are probably in the best position to be able to manage care and direct patients to care that is most cost effective. So we're seeing that. Only 31% of accountable care organizations in the country actually generated enough savings to be able to share in that savings with Medicare. It improved from 2014, we're 27%, so we're only a little bit less than a third of all the accountable care organizations operating in the country as of 2015 were actually able to get a paycheck, a check back from Medicare because they shared savings. Now you might say, well, cost isn't all of this. What's really important as well is how well are we caring for our patients? And if we believe that the quality scores that ACOs use, and parenthetically, ACOs use 33 quality measures and patient satisfaction measures that are all outpatient-based. They're not inpatient-based, they're outpatient-based. If we believe that these measures reasonably reflect the quality of care we provide, and that's very arguable, and who better than we to design systems that measure our quality. But for now, we have these 33 measures. So if we can kind of suspend our disbelief for a moment and say that these 33 quality measures do indeed reflect the quality of care provided by an accountable care organization, then quality has improved. Quality has improved for ACOs from year 1 to 2, but interestingly, there isn't a direct relationship with savings. It does seem in those quality measures that physician-led, and get this, smaller ACOs seem to perform better nationally in the quality measures than their larger and hospital-led counterparts. Slide 9.
Slide 9.
Thank you. So this is now I want to kind of show you some rural accountable care organization performance. And here's a summary of it. So I also kind of mentioned that physician-based, primary care-based ACOs tend to do better with shared savings. They tend to save more money than the hospital-based systems. So, and we saw that in rural as well too. There is also a program that Medicare, or CMMI implemented called the Advanced Payment Program that allowed some upfront money for small ACOs to get started. Interestingly, those organizations did relatively well financially compared to their counterparts. And that was designed specifically for rural ACOs, the Advanced Payment Program. It didn't seem to be that much significant savings associated with ACO size or experience. We expected larger ACOs and more experienced ACOs in rural areas to actually perform better, but that didn't turn out to be true in the financial realm. And then moving to quality, here's some surprising findings. Rural ACOs tended to perform better than their urban counterparts under 3 domains of quality. 1, care coordination and patient safety. Number 2, preventive health. Number 3, at-risk population domain scores. So at-risk populations might be diabetics, for example. So that's where rural performed better than urban. But get this, urban ACOs perform better than rural in patient and caregiver experience. We always thought that we were the best people at patient experience, at patient satisfaction. Yeah, the data really aren't telling us that, at least initially, with rural versus urban ACOs. But importantly, both rural and urban ACOs in general, kind of on average, improved their quality moving from 2014 to 2015. And again, that's a critical part, if not the most important part, of that value equation, improving the quality of care. So whether or not it was the ACOs itself did it, do we have a cause and effect here, or is this simply a correlation? We don't know yet, and we may not know for some time. But nonetheless, we can say that ACOs are associated with improved quality of care moving from 2014 to 2015. Next, slide 10.
Slide 10.
So here's some more current RUPRI ACO research. We found on average that the quality performance was lower on average than urban. But there's larger variation among the ACOs. So it's a mixed bag that's very hard to be able to sort out. This is kind of looking at total quality scores, so everything all together. So we're not performing quite as well as the urban on average, but there's a lot of variation in that performance. We did find that quality performance was positively correlated with being sponsored by a hospital system. Here's where that experience did show up, participation in the program greater than a year. Also, I mentioned that advanced payment. That seems to be correlated with positive performance. Larger beneficiary panels. And get this one, a greater percentage of primary care provided by advanced practice providers, those be physician assistants and nurse practitioners, or in health centers, community health centers or FQHCs. And next slide.
Slide 11.
So I want to summarize here kind of what we believe are looking to be the key success variables with ACOs. This list may change over time as we get more experience. But right now, these seem to be key success factors for a success. Wait a minute, that's repeating myself. But none of the key success variables for ACOs. So physician engagement and leadership, including prior activity in those organizations prior to when they became ACOs. I remember having a conversation, a rural accountant. Some of you may have worked with John Sheehan from BKD in the past. And John and I were one time we're having a beer and talking about hospital CEOs. That's what doctors and accountants do a lot. Talking about hospital CEOs. And John said something to the effect that a hospital CEO's most important job is developing and nurturing good physician relationships or good medical staff relationships. And I kind of paused and said, John, man, you're the numbers guy. What's with this, kumbaya, developing relationship stuff? And he said, oh, no, Clint. I'm all about the numbers. It's the physicians who actually make or break an organization with their pens. He said, so what we really need is physician engagement, physician involvement in making decisions that are wise for developing value in an organization. Physician engagement leadership was a critical success variable. Next was collaboration, again, with those physicians and hospitals. So collaboration kind of across the aisle between physicians and hospitals. And when I work with a hospital CEO that says things like, I'm blessed by my physicians, and I have work with physicians that say, man, are we lucky to have so-and-so who is our hospital CEO, man, my job's easy. My job's easy. That's what we really need. I wish I could say that sophisticated information systems, IT systems, weren't necessary, but they are. So increasingly we're finding that this idea of managing the health of the population or managing financial risk isn't something you can kind of do on the back of an envelope. Nonetheless, we're going to need sophisticated information systems and increasingly population health management systems, which unfortunately are different than the typical EHRs that are being marketed right now. We do need a scale for investment or initial outside source of capital. That advanced payment program I was describing previously from CMMI is an example of that. Developing an ACO is not cheap. It's been estimated 1.6 or $2 million. So this isn't something that most critical access hospitals can just drop $2 million worth of cash to be able to develop one of these. So we generally need some sort of investor or consolidator to help develop the infrastructure necessary to develop an ACO. And then lastly, effective feedback loops of care for the providers. Using my own example, you mentioned, or Kim mentioned that I work as an ER doc, and I do, and I work in a large critical access hospital that's part of a quite large national system. We use Epic in the emergency department. I do my, dutifully do my clicking. I don't dictate, so there should be lots of data available for me to review. I get zero. I don't know what kind of quality I'm producing. I'm getting zero feedback. So hopefully all of you are very different than my experience, but your physicians, if they're going to improve, they need data that's meaningful, easy to understand, easy to act upon to make those meaningful changes to improve the value of care we deliver. Next slide.
Slide 12.
Thank you. So you might ask, why should I think about joining an ACO? Why should I think about this? Well, when only less than 1/3 of hospitals are getting shared savings, and Clint's already telling me that it's kind of expensive to develop these things, why would I want to do this? Well, I'll tell you, here's some ideas. One, we need in rural healthcare, we need experience in developing the capacity, the resources, the expertise to improve the health of our populations, the people that we care for. And you can start small with an ACO currently. We also equally need to understand, how do we manage financial risk? How do we understand what we are costing Medicare for the care we provide, and we understand what our competitors are costing Medicare for what we provide? We need data, and that's the next step in. We need data to be able to understand how best to manage the health of a population and manage financial risk. And one of the neat things about being an ACO, is you get all the Medicare patient claims, no matter if the patient is at Mayo Clinic in Scottsdale, Arizona, or it's in your backyard. 35 miles down the road, and we don't know. So you get all those claims data regardless of where the care is received, and we get information regarding cost per member, which is the key variable in understanding how to reduce costs. We can develop a competitive advantage. It is increasingly difficult for us to recruit high-quality providers, high-quality primary care providers, physicians, nurse practitioners, physician assistants. And if we can demonstrate that we are in the business of providing high-quality care and great patient experience, and if we can demonstrate that we are doing so in partnership with our provider community, that is the organization that I'm going to want to associate with. And that is the organization that I think new graduates are going to want to associate with. And they will be interested also in moving, how to being successful in MACRA. We won't talk about MACRA at this time, or the quality payment program, but nonetheless, that's an alternative for some ACOs to be able to move into what's called the alternate payment model part of MACRA if you're an at-risk ACO. And lastly, my last bullet here is to understand your organization's value and how you as the cost and quality of care, and demonstrate that to your potential partners. And then also how best to optimize your value in the future. Remember that the future of healthcare is not going to be simply heads in beds. And right now, in cost-based reimbursement and critical access hospital, your financial strategy should be to put as many people in your beds as possible. That's the way you're going to maximize your profitable insurance contracts, is to put as many people in the hospital as possible. Now stop for a second and ask yourself, is that the way you want your mom or dad or friends and family to be cared for? To be cared for by a hospital whose financial goals are to put as many people in the hospital as possible, or a physician's financial goals to see as many people as possible during the day in his or her clinic without everyone's hair being lit on fire? No, of course not. What we really want is we want high-quality, compassionate care and the precious resources in our society to be used wisely. That's what we want. Next slide.
Slide 13.
So this is the value model for population-based care. So think about the value-based care equation, and that in fee-for-service volume and revenue is really considered a loss unless we're actually doing primary care, which obviates the need for more specialty care. There's direct program costs. There's cost reductions, incremental cost reductions or increase from lower or higher fee-for-service volumes. And then from that, we see shared savings revenue potential. So this is how we kind of figure this out. And fortunately, we have the person on the phone who can help you do this expertly, is figure out how your organization can make the value-based care future work best for you. But really, the end game is this. How do we improve our capacity to care for and manage effectively a greater number of patients? How do we do that? Because eventually what we're moving to is global payment systems or capitation, in which we get a set fee for per patient or per beneficiary. And in that situation, we want to care for as many people as possible. So how do we do that? And that's the real win. And some of you may already be tracking on what's happening right now in Maryland, where hospitals, including rural hospitals, are receiving a global budget based on number of patients. They're doing a demonstration of this in Pennsylvania right now, and Vermont is coming up fast to try to do this as well. All of us are watching these demonstrations very, very closely, but that we feel is the end game. That's the end game. So we need people, experts like Jane, on this call today to help us figure out the finances to be able to move from where we are now to a world in which we receive a single payment for caring for patients effectively and with high quality. ACOs are a stepping stone in that direction. So now let me kind of describe this pro forma or Excel-based tool that we've designed and developed to help you do this. Next slide, please.
Slide 14.
We spent several months developing this Excel-based pro forma tool. What we wanted to do is we wanted a hospital CEO, a critical access hospital CEO or CFO to spend less than an afternoon, maybe 2 or 3 hours tops, to be able to fill out a spreadsheet to provide a prediction of financial loss or gain based on joining an ACO. The model projects either increased revenue or loss compared to baseline over the next 5 years based on certain assumptions that you'll enter and Jane will talk about further. The development of the tool was not nearly as easy as you think it might be. We found that one of the key challenges for us was a tension between making the tool relatively easy to complete. You shouldn't need to hire your accountant to complete the tool, but we still wanted to be able to defend the results. I wrote here in this 1 to 2 hour completion time. I think 2 hours is probably more likely. The tool itself is Excel-based, and Jane is going to walk you through that tool briefly. It is publicly available. This is free of charge. Anyone can use it. Although, if you do, we'd really like to hear about your results or your experience with it. We are always trying to improve these things, our tools that we produce, and we're producing this for the Rural Health Value Project. So your feedback to me and or Jane would always be welcome. But the key is that it's publicly available and it's free. Again, the goals here, as I mentioned, is to forecast revenue and expenses if a CAH joins a parent ACO versus the status quo of not joining an ACO. And a parent ACO would be what we call an ACO consolidator. And probably the best example of an ACO consolidator, although there are several, is Caravan. It used to be called the National Rural Accountable Care Organization, NRACO, but called Caravan. So some of you may be familiar with Caravan and Lynn, who is the CEO. Importantly, the pro forma, or this tool, is directional. It gives you a sense of direction. It's not something that we'd say it stands by itself. There's certainly more analysis that's required before you decide to pursue an ACO strategy. But this is a start, and this is a help, and that's what we hope it will be for you. So now, Kim, if you could please bring up the ACO Pro Forma tool, and for those of you at home or work, if you look at slide 15, this will tell you how to bring up that tool, the websites to go to and where to click, so you can open this Excel file on your desktop. And after you have done that, Kim, if you would turn the control of the slides over to Jane, or however you two want to do it, and then we'll move forward and describe this tool to the folks on the call.
Great. Thanks, Clint. Good afternoon, everybody. My name is Jane Jurzak, and working along with Clint on the team that actually, in a sense, provided feedback for the tool. As you open up the tool, you'll see that it has a number of tabs. We're certainly not going to have time on the call today to go through all of the tabs and the inputs. But when you first open up something with this many tabs and this many colors, it's often very overwhelming. So the purpose of today is to get you introduced to what this tool is, what it does, where the data comes from, and really the factors that provide sensitivity to the outcome of the tool. So the first tab is what you'll have on that PowerPoint slide. It's really the instructions and inventory. And the goal here was for us to have you, in a sense, get everything in front of you before you would get started on working on the tool, such as your cost report, such as some of the metrics in here. So it's really reading the instructions in inventory before you would get started, or your CFO or analyst would get started on this tool. What I want to really show you right now in some level of detail is the example scenario. What this example scenario is showing you a picture. This is not a working document, but it's a picture. All the numbers are fixed of the end game. So before you or your team member would get started on this, I think it's important to look at this example scenario. What this example scenario is doing is showing you your baseline activity. So from your financials, from your cost report, it shows you your revenue, your allowances, your, in a sense, net reimbursement, your total expenses, and your operating margin. This top part, which is rows 30 to 42, is your whole world, your consolidated financial. It's then broken out in the following rows between the hospital P&L and the physician P&L. So the hospital and physician P&L, in a sense, roll up on this template into the consolidated P&L. So you'll see this is a typical critical access hospital with reimbursement of about $30 million, total expenses of about $28 million, and $2 million in a margin. It's got 3,183 days. It's got some outpatient visits, 32,000, and 34,000 physician visits. So that's really the starting point. What this template on this tab is showing you is if we just move this organization out 5 years based on some minor inflationary increases in revenue as well as in expense, what might status quo look like for this organization? So you'll see in this sample the number of days is going up slowly as well as the number of visits and the number of physician visits. And you can see the bottom line is going up slowly. Then if you turn to the row starting with J, you'll see on this tab the same baseline, but rather than, in a sense, what we think might be status quo, you'll see, in a sense, the summary of what your financials might look like with this set of assumptions in joining an ACO. So you'll see what's happening to your revenue, your allowances, your net reimbursement by year, what's happening to your expenses, and what your total operating margin might look like. And then column R is really telling you the difference. What happened in this model based on the assumptions that you plugged in, the impact of joining an ACO. So this cumulative impact is fairly dramatic because it's a 5-year summary of impact. In this particular example, you'll see what is, in a sense, trying to portray to you that if you are part of an ACO, there's a strong incentive to reduce inpatient services, reduce costly services. Those are inpatient services, emergency department services, things that we might go to a facility for. So in this example, you can see that the days of care actually went down. So our Medicare days of care went down. Our Medicare outpatient activity went down as well. We're trying to manage that patient more effectively, not come in for the readmissions, not come in for the frequent ED visits. So those 2 items went down, so we would expect our total revenue, our net revenue, to go down as a result of that. The expenses as well, this model is based on a fixed and variable expense assumption, which is fixed in the model, but you can change it if your hospital is different. So you can see then what happened in this scenario to expenses. They went up. So in total, over this 5-year window, you can see the net operating margin was down roughly $2 million. So if we dig further into the detail, what do we see? We see that days of care went down, outpatient visits went down. Conversely, we have more physician visits. The access to efficient care is through that primary care network, through your rural health clinics that Clint spoke of. That's where we're better, more effectively managing care, is through that team-based care model. That's where we can have more impact on population health management. So if we take a look at the hospital side of this equation, in the example, we have a significant reduction in Medicare reimbursement. So you can see that very, very significantly. We were able to reduce hospital expenses, but in the model, we've conservatively set variable expense in the hospital quite low, because that's really your world. So you can see that expense went down much lower than revenue did for reducing our 1,467 days and our number of outpatient visits. We've added in here, and this is just a number that you can add, in a sense, perhaps a more realistic number, but the cost of actually investing in an ACO. I think Clint mentioned between $1.5 million and $2 million to set up an ACO. This total ACO expense may not be all on your back. You might, in a sense, be only funding a share of this cost. But again, in the sample, it's showing the whole cost of the ACO, $1.6 million. So that's why the impact to the hospital is very significant, minus $2.2 million in this example. Conversely, the physician group is doing better. More volumes, more Medicare activity. Yes, expenses are going up somewhat, but we're not hiring another physician or more staff. We're just better using the resources. But you can see the positive impact in this example on the physician group is not nearly the impact on the hospital group because we are, in a sense, adding cost of running an ACO. We are losing money by having less patients, those 1,400 inpatients, the 7,800 outpatient visits less. Here you can see we are picking up a shared savings payment in this example of $2.1 million, but it's not enough to offset the loss of the inpatient and outpatient activity and pay for the incremental cost of the ACO. So this is kind of a starting point of giving you a sense of when you put in your own data, what it will tell you. The next tab is, in a sense, a detail, and this is probably the most confusing tab for people. So I'm going to pass over it for now. This tab called Scenarios is actually your data getting populated. So what we have is a number of yellow tabs called Required Inputs. And if you plug in your data, and I just populated this example this morning. I just made up some numbers and plugged in this example. And we'll go through what the inputs are. But if you put in the inputs, the required inputs that we're going to go through, this tab automatically populates. It automatically populates. And I set up this example where we're actually a little bit better than break even. So we're getting some shared savings. We're losing some money, but we're getting some shared savings. All in, we're doing better than break even. The charts and graphs also automatically populate. How many physician visits do we have? What are the financials looking like? So those really automatically populate. It's really the required inputs that you want to, in a sense, be ready for when you're setting up to do this work. Most of the inputs on this page are coming right off of your Medicare cost report. We have the worksheet and the line number and the column number articulated for you. You just plug in anything in yellow off of your cost report. This is coming right off your cost report. We also have a page called Hospital Inputs. And what this page is how many Medicare patients do you have in your region, and what percent of those folks are you really caring for? So in this example, I just made up some numbers in terms of 20,000 Medicare patients in the population, and that you're caring for about 30% of them. So this is a hospital input page on number of Medicare lives and what percent of those Medicare lives do you care for. So it's quite easy to plug in. We also have you putting in some inputs in yellow, and this has to do with basically the penetration rate for your physicians. Again, I plugged in a 30% penetration rate. There's also what's called an ACO operating expense tab here, and this is also, or an ACO population expense. For the most part, other than plugging in these yellow tabs or the yellow cells, everything is fairly automated. What this tab does is explain to you if you are going to get any type of shared savings that goes to the critical access hospital. So in my example, we are, in a sense, in a shared savings scenario because our overall savings rate of 4% was higher than the minimal savings rate that we need for 5,000 beneficiaries. So all you need to do is plug in the number of beneficiaries in your market region that would be part of your ACO, plug in a sense, what expense reduction we would see outside of the critical access hospital with the other members, and everything automatically flows for you to the savings page. And the last page I'll point out to you is in the model, we have built $350,000 of startup costs for the ACO, and you can see the ACO costs per year. You can change those if you wish. They're at least getting you started with the model. And if you want to get very, very granular, you can actually plug in by type of cost all these various costs of running an ACO. Or you can simply do it in the summary format. And what you're going to end up with is this nice template of scenarios. So it's very easy to change some of your assumptions in these 4 yellow input tabs and come back to your scenario here in column R to say, what does this mean to us? Would we be worse off by joining an ACO, better off, and what would our range of possibilities be? So as Clint mentioned, this is very, very directional, but it's giving you a tool that you can put in your costs from the cost report primarily. You can put in how many ACO members you would have. You can put in what you think is going to happen to your volume by better managing your population. And out will pop this scenario. Would you be better off? Would you get some shared savings money compared to the cost of investing in the ACO, compared to the sheer reimbursement reduction of lowering your inputs, lowering the volumes of services for that population? And that's what this template is really designed to help you understand. So it may look overwhelming, but you really can't mess anything up. You can just plug in the inputs on the input pages, come back here to the scenario tab, and see what it tells you. See what it tells you. So that's how this worksheet works. Again, it's that balance between how complex to make it versus how sensitive to make it or how helpful or useful to make it. Again, it's free, so you're welcome to download it and start playing with it and see what it tells you in your market. So Clint, I don't know if we have any time for questions. But really, at this point, I think if there are any questions from the group of how to use it, this would be an appropriate thing to do. Or if we, in a sense, want to make sure that everyone has the ability to download this template from your website, make sure that they're able to do that, I think would also be important.
Great.
So Kim, Kim, you could probably open up for questions. I would just say you could open up for questions, and also if we could make sure that folks have both my email address and Jane's email address. Both of us are very responsive to emails. I don't have all the answers, but I often know where to find them. So, so feel free to email me or Jane, who's way more expert than I am, and we'll help out.
Great. Yeah, if anyone has any questions, from Clint or Jane today, you can press *2 to unmute your phone line, or feel free to ask a question into the chat box.
Hi, Clint and Jane. This is Sally Buck from RHI. Did you clarify if the hospital is using the Forma if they're estimating just their Medicare patients in the ACO, or all patient revenue and expenses?
That's a great question, Sally. Just so everyone hears, our hospitals, in a sense, in the model, typically, assuming that just Medicare patients are in this model of ACO or all patients. The model is flexible, but for the most part, I would suggest you start by putting in one payer, such as Medicare, that would be in the ACO. If you have non-Medicare ACO, in a sense, business that you want to help understand how this works, the model works for that as well. So it would work for any type of ACO. It happens to be set up, in a sense, more for the Medicare market, but it would work if you had other than Medicare ACO business in your facility.
Great. Thank you, Jane.
Here's a question from the chat box. If a critical access hospital is not part of a physician-led ACO, so there isn't shared savings, will the model help you know how bad it could get?
That's a really great question. And the answer is yes. And what you would do in that case and how you would use the model is simply set the ACO expense to 0 because you would not be part of the ACO, but the model would work to the perspective, and you would set any shared savings to 0 because you wouldn't be enjoying shared savings, but the model would work by simply reducing your volume, your inpatient volume, your outpatient volumes, maybe increasing physician volumes, because the hope would be the access to your physicians would be better, and you can see what that might do to your overall reimbursement based on the assumption of fixed and variable costs that's in this model, which you may want to revisit on the input tab. The input tab for the hospital piece gives you that ability of changing the fixed variable relationship, but it would indeed give you some sense of how bad it would be by virtue of how your inpatient volumes might decrease. or your outpatient activity might decrease, and your cost might not decrease by that same percent because we've got a lot of fixed costs in the critical access community.
Good question.
Great. Yeah, great question. This person is following up, typing, but for right now we'll go to a different question. What assumptions does the model make about the proportion of shared savings that would go to the critical access hospital or shared losses?
Okay, well, let's take the shared losses first. In the model, we're assuming shared savings. As Clint mentioned in the presentation, at this point, the risk is upside, at least with Medicare. So that's the first part of it. With respect to what percent the critical access hospital would get of the shared savings, it's all about this magical penetration percent. So in my simple model here, I had assumed that in the local market area, the critical access hospital would be getting a 30% of the Medicare folks, or a penetration rate of 30%. In that example, you would be enjoying 30% of the shared savings. So the shared savings percent that you would get is directly related to your Medicare penetration percent. If you are only seeing 10% or caring for 10% of the Medicare business in that ACO, then you would be, in a sense, getting 10% of the shared savings.
It does depend. The percent or the amount of money that you get in shared savings depends in great part on the number of patients that are attributed to your ACO, or the patients that are attributed to your ACO. And so you really need to know that number, and we need to know their baseline. So if we have, just using an example, we have 5,000 patients attributed to our ACO, now we need to know the total cost of care for those 5,000 patients, no matter where it's provided. That's the key. No matter where it's provided. If it's provided at one of your competitors, it counts against you. And if it's provided at a snowbird's winter residence, it counts against you if that particular patient is a member of your ACO, a beneficiary member of your ACO. So then once we see that total amount of money spent by those patients compared to what's predicted, then we'll see our shared savings. Now, it may have been that the questioner was asking another question, and that was, what percent of shared savings if we join a parent organization? I think that may have been one of the questions. So if we join a caravan, for example, what percent of shared savings will we receive? And it depends on the contract that you have with the parent ACO. It depends how they share their savings with you. It's the same kind of question that asks what kind of shared savings will we have with our physicians? Well, it depends. The ACO language is quiet on that. You can share savings essentially any way that you want, but that's a decision among the ACO, how you divide up the savings among yourselves.
That's a very good clarification.
A key input seems to be the Medicare population. What source do you recommend to get that?
The recommendation and the way this model was set up is to use your most recently filed Medicare cost report. And all of our critical access hospitals would have one of those. And if you take a look at the hospital input tab, it's really designed to, well, for the required input tab, it tells you exactly the worksheet from the cost report, the part, the line, and the column. So the thinking is that if you can just have a paper copy of your cost report in front of you before you get started, and you have a sense of how many ACO lives would be in the ACO and what percent, in a sense, would be attributable to your primary care physicians and extenders, those are key things that you need in order to start this process.
If I could add to that, Jane, if I could, So what Jane just described is on what's called the Required Inputs tab. That's where you use your cost report. Now, the person who asked the question may also be asking, well, where do we find out about our Medicare penetration rate? So Medicare penetration rate is a combination of two variables. The variable is first your market share, so the number of patients out of the total number of patients, total Medicare patients in your service area. So say we see 30, let's just say there's, again, 6,000 patients, Medicare beneficiaries in our service area. If we care for, over the past year or two, 2,000 of them, then we have a 30% market share. But we also need to know what percent of that Medicare services we provide to that 30%. So it's a multiplication. So if we lose 50% of our services to Scottsdale, Arizona, then we have 50% utilization times 30% penetration, or 30% market share, so we actually drop down to 15%. That's the penetration rate, I believe. You as organizations may have your market share data, or your hospital association may be able to provide market share data, or your consultants may. Yes. Jane, could you help me if I got that right?
Yes, that was very good. And Medicare now has a lot of claims data published online for various hospitals of all sizes. So you can actually kind of see, if you go to the Medicare data files, how many visits and inpatient days and so forth you provided versus anyone else who may be in that ACO. That's correct. That's correct. So you're in a sense swimming and sinking together is really what we're saying, because the shared savings possibility is really dependent on how well everyone does at managing that book of business, that group of Medicare patients, those attributable lives. So you, in a sense, sink and swim together on the opportunity to have shared savings and the opportunity to keep those shared savings whole and not get them ratcheted down due to, in a sense, perhaps less than favorable quality metrics.
Great. Thank you so much. I know we're past the hour here, but if you have a few extra minutes, we have a couple more questions.
Sure.
Okay.
You guys good? Okay. We are an AIM ACO. How can we factor in paying back AIM?
Jane can add this too, but this model does not consider AIM. It does not. But I think that somebody with more expertise at this than I could certainly figure out a way to include a reduction in your shared savings amount that has to be paid back to Medicare.
Right, and what I would suggest too is on the summary page, you could simply add those payments in by year if that was something that you knew was going to be happening to your hospital. So that would be the only place I would have it, but Clint is right, it's not designed particularly for that model.
All right, and our last question. Cost reports don't include expenditures from other facilities, so how does the model calculate total cost of care for an attributed beneficiary? Example, how does the model get snowbird data?
Good question. If you look at the last tab of the model, it is telling you by region of the country, by state, by county, by, in a sense, code, zip code, what the baseline Medicare cost per member is. So that's baseline. Then if you go to the yellow tab called ACO population expense, that is where that number would come from, those regional rates, depending on what region you were in. You then, in the model, have to make some assumptions on the ability of everyone managing that care to either reduce the cost per member on average by 1%, or is the cost per member increased? So it's simply an assumption that you put in on what's the change or the delta from your current or baseline expense. So until the ACO gets going, you just have the baseline. But then you have to, in a sense, in this model, perhaps do a few scenarios to say, what if our overall expense per member goes up by 2%? What if it goes down by 2%? And see what the impact may be on the scenario tab by those various assumptions.
All pro formas require, or all models like this, projection models require assumptions. And of course, the output of the model is dependent upon the accuracy of the assumptions. But the primary assumptions that you make on this model are what is happening to the volume of care in both inpatient, outpatient, and physician practices. That's the main variable that you have to make assumptions about. And in general, what we see in ACOs is a slight decrease in inpatient care and a slight increase in outpatient care. That's what we generally see. For a critical access hospital, what we really want is a decrease in the tertiary care utilization. That's what we really want. But that's the challenge, of course, is how much control do we have over that? So the idea, as Jane said, we're all in this together, but yet we're still running a business. So to be somewhat mercenary about this, the way to make this work best is for your physicians to be aggressive about good care management and choosing wisely which specialists and which distant hospitals they use for care that cannot be provided locally.
All right. Thank you so much, Jane. Thank you, Dr. McKinney. This has been an excellent webinar, and also thank you for sharing